Good morning or good afternoon or good evening, wherever you might be joining us from. Well, we're delighted to be here in the fifth of a series of town hall meetings sponsored by Axiom. Welcome to those of you who are joining for the first time or those of you perhaps who are coming back for a repeat viewing. This session is actually going to focus on GI cancers. And I'm pleased to be co-moderating this meeting with my friend and colleague, Dr. Eileen O'Reilly, as well as a distinguished panel of colleagues and really leaders in their fields, in their respective disciplines. We're going to be discussing today just the tremendous impact that COVID-19 has had in the cancer world, and specifically to GI cancers. Certainly those of you who are joining in your practices have been affected by this and really thinking through what are best practices and where we go from here. So I'd love each person on the panel to please introduce themselves, maybe share a little bit about your discipline, the institution you're affiliated with, and then once we make introductions, we'll have each person, I think, just share in broad strokes sort of the impact of COVID-19 on their practices, what they've been doing at their institutions, et cetera. So Eileen, do you want to start?
Great. Well, thanks, Andrew. And just to echo your welcome to everybody, we look forward to a really lively and interactive discussion here, just how life has changed in the practice of medicine and how it impacts GI malignancies in particular. And we have a very global perspective on the panel and representation from East and West and the center of the country. So all at different points in where the pandemic is currently. So I'm Eileen O'Reilly. I'm a GI medical oncologist here at Memorial Sloan Kettering, focused on pancreas and hepatobiliary malignancies, and really appreciate the opportunity being here today. So I'll pass maybe to Alice next.
Good morning, and thank you for the introduction. My name is Alice Way. I'm a surgical oncologist, and I also specialize in pancreas hepatobiliary malignancies at Memorial Sloan Kettering here in New York. I will pass it on to Dr. Stephen Chan.
Thank you, Alice. I'm Dr. Stephen Chan. I'm a medical oncologist. I'm from the Department of Clinical Oncology at the Chinese University of Hong Kong. In my daily practice, I do see all GI cancers. In the research aspect, I'm more focused on the HPP cancers. Maybe Daniel, your turn.
Sure. Hi, I'm Dan Catenacci here in Chicago at the University of Chicago. I'm a GI medical oncologist, focusing on gastric, esophageal, and G-junction cancers. And I will pass it on to Dr. Goodman.
Thank you. Thanks for the invitation to participate. I'm Karyn Goodman. I'm a GI radiation oncologist, and I'm at Mount Sinai Hospital in New York City. I'm also the Associate Director of Clinical Research for the Tisch Cancer Institute. And I'll pass it on to Dr. Pishvaian.
Hi there. Thanks, Andrew and Eileen, for the invitation. Thanks to be able to join this panel. I'm Mike Pishvaian. I'm a GI medical oncologist with a focus on pancreatic cancers and also phase 1 drug development. I'm newly joined to the Johns Hopkins Medical System. I'm very glad to be back in DC. And actually, I was going to say that one of the direct impacts of COVID that I have felt is being new to a system, having to reestablish a patient volume. It's been amazing to feel the impact of very few new patients coming into our center. I think that across the country, there's been a pretty big drop-off, particularly in new patient new patient visits. But the sad thing is, we know that the cancer patients are out there, and we know that there's going to be a surge of them coming probably in the mid to late summer.
Yeah, that's a great point. And again, my name is Andrew Ko. I'm a GI medical oncologist at UCSF in San Francisco, with a focus in pancreatic and upper GI malignancies and clinical trials. And so I think to kick off this discussion, we wanted to just talk about, obviously I think COVID-19 has hit each of us in different ways, and I think the prevalence has been different at our respective cities and institutions that might somewhat inform our practices or how we've tried to handle the situation in terms of care for our cancer patients. And we also know that it's things are changing almost on a day-to-day basis, and in terms of the policies we implement, it's what we decide on one day may be very different the following week. And I think, I'll say thankfully, we're even starting to think about a recovery plan and what that looks like. In San Francisco, thankfully, we've really, for a long time, been preparing for this surge that we actually have never quite seen, and the incidence has been quite low. Our asymptomatic, our rate when we test asymptomatic individuals of positivity has remained less than 0.5%. And so as we have that information, it's sort of informing, well, what should we be doing in terms of testing staff and testing patients? And I think we'll come to that in terms of discussing how your testing practices are at this point for your cancer patient population. But maybe before we go there, why don't we open it up and maybe start with our New York colleagues to sort of discuss just broadly the impact of COVID-19 over the past couple of months at your institutions. Your volumes, how you've changed patient visits, how you're just how you're changing your practices right now.
So Karyn, would you like to start?
Sure. I think, as a Mount Sinai being sort of the epicenter in New York, we became a COVID hospital. And I think I think my role both as a radiation oncologist and also in the wearing the hat of the Associate Director of Clinical Research for the Cancer Center, we had to make a lot of pretty rapid changes in how we were managing patients and how we were performing clinical research. And so as it became apparent that the numbers were rising really rapidly in New York City and the risk to our patients of coming into the hospital, coming into Manhattan, and just the lack of resources as we redeployed many of our physician resources, our support staff to taking care of COVID-19 patients, we really couldn't manage being able to run clinical trials. So we, as many places across the country did, we really shut down our cancer clinical trials program. And so having been there for about 4 months in that position, I was hired to really develop our clinical trials program, I basically shut down about 140, we had 140 trials open. We went through the process of asking each of our disease teams to identify the 1 or 2 trials that they absolutely felt were necessary to remain open. And then we basically went down to about 19 trials open. And we were able to maintain most of our patients who were already enrolled on studies to come in for treatment, but we really moved to telehealth, and through many of the guidances that came out from the NCI, we had our patients doing most of their lab visits, any evaluations for AEs by local physicians when possible. And this was actually something that was supported through a lot of the national guidelines. And we really went from our normal numbers of trial patients. We dropped that by about 80% over the month of, I would say, April. In terms of radiation oncology, it was a very interesting sort of mix of what we were seeing. I was certainly seeing fewer new patients for GI cancers, but except for certain things like, say, HCC, where we had really closed down we were not doing any surgeries in the hospital. We couldn't afford to use any of the ICU beds after the post-op, and all of our anesthesiologists were redeployed. So we did see quite a few SBRT cases for HCC. I was doing a lot more hypofractionated approaches for various types of cancers. And in situations where we felt that we needed to hold somebody over with local control, and for some period of time, we were doing some additional treatment. So our clinical volume in the Department of Radiation Oncology really was only down about 30% over that period of time in April, whereas most other departments in the hospital were completely down to, ambulatory care was down to, zero for many of the departments. So we did maintain a practice. We had to really learn how to manage the social distancing, what to do about testing for patients when they came in. And this was, as Andrew said, a work in progress, because things were changing on a daily basis, when to test, what kind of PPE our therapists were allowed to wear. We eventually were initially they were told not to wear N95s, but because as opposed to the 0.01% of patients that tested positive in the population in San Francisco, in New York City, it's about 20% of patients. And then amongst our cancer patients, it was also on the order of about 10 to 15% of patients were testing positive for COVID. So we had to anticipate that many of our patients were asymptomatic, and we needed to take precautions when they came in. So I'll leave it at that, but it was really a transformative time in terms of our ability to take care of our patients. We had to really make decisions that I would never have thought I'd had to make about delaying treatments. The only really exciting thing about what happened was that because we had such a strong clinical trials program in the Tisch Cancer Institute, we actually became the main group that was helping to support the COVID-19 clinical trials. So our teams actually ran our convalescent plasma study. We ran some of the development of a COVID-19 protocol review committee, so that we really helped our ID colleagues and pulmonary colleagues across the institution to stand up a clinical trials program, because they just didn't have that same infrastructure that we had in the cancer center.
That's great. Dr. Wei, I'd really be interested to know your perspective from our surgeons. I was just struck by just how operations almost came to a standstill, except for the absolute most vital ones. And I imagine in New York, you might have faced something even more drastic.
It's absolutely true that COVID had a huge impact on surgery, the entire profession of surgery. Elective operations, orthopedic operations came to a standstill, both statewide, but also nationwide. And really, a lot of surgical departments had to implement disaster modeling and disaster teams, and it really made a big difference. So at Memorial Sloan Kettering, where I work, there's a COVID-19 team for surgery, and they worked with all of the stakeholders within our institution, but also with other hospitals like Mount Sinai or other hospitals in our region, trying to plan for capacity planning. So in terms of what they did first, in terms of cancer surgery, which I think is unique and different from what we would consider normal elective surgery, is that we worked to try to identify what was considered truly elective surgery from what was deemed essential cancer surgery. So scheduled surgery, but certainly not elective in the sense that it could be delayed for an infinite, or even for some patients, a short period of time. So really the first step was try to identify what was elective, what was essential, and of course, emergency surgery was always planned for within this context. It initially was trying to understand what the impact was going to be immediately on the patients. And so, for example, it really did change minute by minute. And of course, there were state and local and then professional organizations like the American College of Surgeons developed guidelines that helped us move forward. But in the early days in New York, where, as you know, there was a huge surge, we were worried initially about whether or not we had enough OR gowns to actually do the cases for the day. So we had to make very immediate, plans to eliminate people from the OR that didn't need to be there, just to save gowns, just to save masks for what we had before we were able to mobilize our PPE and our equipment needs. So that was really the very first issue. We then had to think about modeling for capacity planning. So we tried to increase the capacity for just inpatient beds. So one of the goals was to reduce surgery to allow beds to be available for a surge if and when it came. Trying to make sure there was enough equipment, including ventilators. So one of the main goals of closing the ORs was to free up ventilators for if and when they were required to be used. And of course, protect and enable whatever human resources, whether they be nursing, whether or not they be anesthetists, physicians, or RTs, or other staff be available for the surge that was coming. And also, Memorial is a unique because it doesn't have a big general emergency room. It's not a general hospital, but we certainly worked with our partners and other institutions in New York to see when and if we could share either resources, physician resources, equipment and whatnot to enable other places that were harder hit than us to be to work with them and make sure that we're able to take care of everybody in a timely manner. So, I think we fared, with the initial, after some initial disaster planning and really closing down for a couple of weeks during the peak, we're really thinking about recovery now, and we have been able to model that as well, and also for second and third surges down the road. So that's what we did at an institutional and a health system level. At the individual physician and surgeon level, we have seen the same issues with the referrals have decreased because I think patients are not seeking care, the patients that we do see are quite sick, are very symptom laden, and so we've had to bring them into hospital for some more urgent assessment for symptom control as needed. And then we've worked with all of our partners, as everyone here knows, for GI oncology, multimodality care is part of what we do, and we're very familiar with that. Perhaps in situations where surgery was the first therapy and other treatments like chemotherapy and radiation therapy, the sequence was adjuvant, we've had to reassess those with our teams. I think we're working all together earlier to triage patients early, to talk about what options are available for patients. As Dr. Goodwin just mentioned, whether or not radiation could be something that could temporize or replace surgery or replace treatment. So we've looked at different sequences, we've looked at different strategies to try to decrease the need for surgery emergently, and also to be able to plan in case surgery beds were not available, which luckily wasn't the situation for our places, but certainly was the situation for other institutions in other countries which have had large peaks as well.
Yeah, one question is already coming in, and from a participant who's asking is the list of the surgeries and how you've triaged or decided on what's emergency, or basically what's essential, what's optional, what can be delayed. Is there do you have that available to disseminate? And I think that applies also for RADONC, and if there's any sort of specific or national guidelines that that you can share with this audience, and I guess true for MedOnc as well in terms of recommendations.
So absolutely, the American College of Surgeons came out with general guidelines across not just cancer surgery, but across the entire breadth of surgery. The Annals of Surgical Oncology just published the Society of Surgical Oncology's recommendations in terms of how to manage each type of cancer, what options there may be. These are all guidelines that are very helpful, but certainly at the institutional and at the individual patient level, we have taken these guidelines for essential cancer surgery. And then we have also every section, every department, every disease site lead has also used those as a framework where there's always exceptions one way or the other to just guide what would be considered essential. So certainly we can disseminate those guidelines later. I know in Europe and Asia as well, there have been these guidelines rapidly coming out. But yes, there are resources to look at in terms of what should be considered essential and in terms of timing. I know for GI cancers, for the most part, they are considered essential cancer procedures, with the caveat that other options should be considered when appropriate.
Thanks, Alice. I mean, that's a very interesting perspective. So could maybe change the topic a little bit. One of the biggest impacts, I think, as medical oncologists and the whole medical community has experienced is the transition to telemedicine and what that means and where it's going to be as we move forward, and some of the learning curves for this. So I'd like to ask Dr. Pishvaian and then maybe then Dr. Catenacci to speak on their experiences and their learnings and guidance for us in the community.
Yeah, thanks. I'd be happy to take that. You know, I think that it really has been a bit of a revolution in medicine, unintentionally, unwittingly, where we've had to face this reality of telemedicine. And I think that it is something that is going to be here to stay, because there are definitely some good things that we're going to be able to take away from this experience and change how we practice medicine. Being able to do telemedicine visits has allowed us to be able to see patients actually sometimes more often than we previously were, because there wasn't the burden of squeezing them into clinics. There wasn't the burden on the physical structure and the medical assistants and everybody else within the hospital. It was just a simple one-on-one conversation between doctor and patient. And with technology, the ability to have a full conversation, albeit without an exam, that's the one thing that we're missing, but a full conversation with patients. I've really been able to spend quite a bit of time diving deep into symptoms and side effects of chemotherapy, and to some degree more than I ever had before. You know, in the clinic, sometimes we'd rush between patients 4 or 5 minutes with any patient, particularly if it was being filtered through a fellow or a nurse practitioner. But when it's there, you know, one-on-one between me and the patient, and sometimes I'm spending 15, 30 minutes, sometimes with a new patient, I'm spending, you know, an hour and a half really hearing the full story. I feel like it's been a bit more of an enriching experience. In DC at Hopkins, we've also taken advantage of local labs. So the need to have patients come in to get lab tests done in the hospital has also been sort of pushed aside. And with, again, the ability to get the labs drawn into the EMR efficiently, we're really getting the full picture of these patients in a fairly real time. So a lot less burden on the patients, a lot more time with the patients in some ways, I think has been the one positive experience that we've taken away from all this. At the end of the day, though, some of these patients are really sick and they just do need to be seen, and you do need to press on their abdomen. You do need to just look at them in the eye and face to face and get a sense of how sick they really are and what they really need. And so periodic visits in the hospital are still going to be an absolute necessity.
Thanks, Mike. And Dan, maybe some of the challenges as we've kind of walked through this period of time, and how you see it impacting clinical trial, follow-up conduct, and that topic.
Sure, and I would just echo what the others have said. It seems like we're having similar experiences along the way, and being here in Chicago at another epicenter, and we went on a shelter in place here in the state, you know, mid-March. So everything shut down here as well from a clinical research standpoint, and even visits initially. And then slowly started doing telephone calls and then video when that was up and running. And echoing what Michael was saying in terms of that, and I think in the end we will take. I've seen a lot of questions coming in about what will this remain as part of our staple in terms of providing medicine, and I think there are a lot of good aspects to the telehealth, both from the mobile phlebotomy that you heard, and also just patient convenience, and also, you know, having them drive here to do, you know, a 10-15 minute visit when we could do that at their convenience at home when it's appropriate. I think much of that is actually going to bring that to light, and we're going to actually hold on to that as we get through this crisis. But there are also difficulties having new patient consults where, you know, you really need to be seeing them in person, and you're trying to do this from afar. I think that's going to be a challenge, and still is a challenge in the near future. In terms of the clinical research question you just asked now specifically, similar to what Karyn was describing, initially, especially when this was first hitting at its height, everything was shut down, and all of our staff that runs the whole research arm of things here from a clinical research standpoint, and even the laboratory research was just shut down, and people are working from home, and so all new accruals to studies were closed completely. Part of that was sponsor decisions from clinical studies from global sponsors and large studies, and the rest was from our internal imposing the closures of these studies, at least temporarily. And so patients on studies already, this has been a challenge in terms of trying to provide their care, but at the same time we were acknowledging that we would be having protocol deviations for things that were considered completely non-essential. So PK draws and other things, EKGs that were just built into the things, these were not being done. And so we just generated a list of all of the COVID-related deviations that we knew were going to be happening moving forward on patients already on study. And so, as everyone has been mentioning, that was at the height. And so now, as sort of the dust is settling and we're starting to look at reopening and getting back towards some form of normalcy, we are opening some of our studies that we consider critical. And certainly if it's the patient's only option for therapy and they don't have other treatment options, these are the types of situations where we're opening those types of studies. And I think that it will take a while before we get back up and running completely to normalcy, but we are getting there in terms of that. So those are the aspects with respect to the clinical research at our center.
Great, thanks. And maybe just to get the global perspective, if we might just ask Dr. Lam, in terms of Hong Kong and Asia, a little further ahead of us in terms of the whole trajectory on the pandemic and how telemedicine is and where you are with clinical research.
Thank you, Eileen. Maybe I give a very brief background about our experience with the COVID-19 so far. We have the first case back to early January, and then this is the first, and then we have seen a first wave of outbreak in Hong Kong, mainly due to some imported cases from China, and also we do have some local cases within the community. At that time, probably because Hong Kong people, we have experiences of SARS 17 years ago. So actually we do have some sort of rehearsal. And for example, the hospital, we immediately implement all of the measures. And one way I find quite different from the last time is we do the information. I agree with Dr. Goodman that sometimes information did change every day. But thanks to the social media, for example, each of us communicate with the WhatsApp. Whenever there's a new measures, we can easily disseminate among all of the staff just by the message. So I do find this very useful in our experiences within the hospital management. And then actually, and also the government had tried their best to trace all the cases, to do all the contact tracing, and also some sort of a down-tune and sometimes have control at the border. Actually, we are seeing control of cases in January and February. Unfortunately, we are seeing second wave in March, mainly because in Hong Kong, as you know, it's an international city. We have a lot of business travelers and also students actually travel back from the Europe, US, and for all over the world. So after we have seen a drop down cases, and then in March, we're seeing an increase in the cases again. At that time, actually, we do see suddenly within a day, hundreds of cases coming up. So the government had taken a very strict measure at that time, some gather control, home office, close all the schools. So fortunately, we do see a reduction of numbers in April and in May. But our experience is that it's not that easy to control, because we actually have around 12 days of zero cases from late April to May. And suddenly, a few days ago, we have another 2 cases again. And then we try, because we have very strict border control now, so those cases are not imported from outside. So when we try to do the contact tracing, we cannot identify any sources. So that it probably due to some asymptomatic spread or some silent spread within the community. So some people may say, oh, very optimistic that it will be controlled in July, August. I'm a bit more pessimistic. I think probably you are bound to see some cases, some small outbreak in the next few 4, 5, 6 months of time. So I agree with some of the questions that we probably need some new standard in our hospital. So going back to the question of telemedicine, yes and no. Actually, we have discussed a lot among ourselves. I think there's some challenges. Certainly, we see the good thing about telemedicine. The patient doesn't need to come back frequently. But of course, there's a lot of a communication, medical legal issue that we're still a bit worried. It may not be too mature, but we are doing some. For example, in February and March, actually for those patients who are more less complicated or who can just replenish medications, we can just have a simple phone call and document the dialogue, and then we just ask the family take the medicine back for their patients or their families. We also do some micromanagement in the clinic that we read the history, because in February, we don't want the clinic to be too crowded. So we did have some staff contacting the families to see if they want to delay the appointment. Of course, if they have problem, they can still come back. So I sort of a premature model of telemedicine, but we still don't yet have a very mature model of telemedicine yet, even in Hong Kong. Yeah.
Just to round out the telemedicine question, and this is open to everyone, one of my colleagues at UCSF thinks that it's almost unethical to treat someone or to start someone on treatment or chemotherapy following a telemedicine visit without actually laying eyes on that patient in person. Do you agree? Do you think that that in person is necessary to formulate a specific plan of care and actually to start them on, say, chemotherapy?
I can speak to that. I mentioned that it's very challenging to, have a new consult visit with video. And so we've had some experiences where, I'm not sure if I'm going to which therapy I'm going to give based on what I can tell from just the video conversation. And the next follow-up visit would be an in-person visit just before we get started, just to finalize the plan. Because if you're not sure and you can't tell, it's probably not a good idea to just start therapy without really having laid eyes on the patient beforehand. So I would agree with that to an extent, but at the same time, that initial screening visit on the video can take care of a lot of things. And many patients, for example, the visit can be sufficient and I wouldn't have to see them again for 6 months because they can get therapy locally, for example. And so in the end, also as a plus to all of this, in the end, I think that it may actually help us with clinical trial enrollments in the future, because maybe more patients would get access to our opinion early on just from a video consult, and then we can really, inform them, and then they could really make a decision as to whether or not a trial is worthwhile for them, and then maybe that will help catchment onto clinical trial enrollment in the future. But back to now, I think for your specific question, my preference is that I still see the patient before I actually start a therapy.
I'm just going to comment real quickly that I think that as oncologists, medical radiation surgical oncologists, we know that we tend to have a very special connection with our patients, not to denigrate any other specialty. And that relationship often is something that becomes very, very close. So I agree with Dan. I certainly don't think it's unethical to start somebody without seeing them, but I think to establish that connection, what I've done is typically to do the new patient visit over the video, but then when they get there to get started on that chemotherapy, I go join them in the clinic or usually in the infusion center to really meet them face to face.
I just wanted to comment that before I was in New York, I was in Canada, where there are geographic limitations to care, and so they had quite a mature telemedicine program. And I think that it can be excellent what we're seeing now, because they've been rolled out very quickly. and a little bit ad hoc is probably sort of iteration telemedicine 1.0. You know, it will become much more mature, and there's probably a blended model that might work well. So, you know, previously, because we would take care of patients who live 10, 12, 14 hours away, we had established telemedicine relationships with hospitals where the patients would go to a hospital telemedicine clinic space. There would be a nurse there, a hospitalist, and that they would be able to really be provided with both excellent clinical in-person care by an APP or a hospitalist, and also get subspecialty care at the same time. And I think, you know, that's probably where we'll see telemedicine mature to. I think it can be excellent. I'm a big advocate that that really allows access to patients that wouldn't otherwise come see us or don't have the ability to come see us to get you know, excellent care. But also, even if they are not able to travel to see us, they get the most important thing, which is the right opinion and the right recommendation for the treatment for them. So I think that we should just be, you know, it will get better, the telemedicine. Right now, it's pretty terrible. FaceTime's terrible. The Wi-Fi is terrible. The patients push all the wrong button. Everyone's always on mute. I don't think that will be the future. I hope not.
Yeah, I think I want to echo some of those learning points for us all, right? The technology challenges, the platforms, learning multiple systems in parallel and try to make it work and efficient has not been straightforward. But I love the term blended. I think that really captures it very nicely, that it's going to be both. And I want to echo Michael's point as well, the personal aspect of it, the trust, the relationship. It is hard, I think, to fully capture that in a video setting. And just the laying on of hands, I think we're constrained with that in the current environment. But at the end of the day, I hope it's going to remain an important part of medicine going forward. One other thought about how we might use this is, given geography and space constraints, which maybe will be dissipated because of some of what's evolved, but how we do multidisciplinary care in terms of our surgery colleagues, our radiation colleagues, our medical oncology and supportive care team being, once we can figure out the technology of linking in and in one consultation, I think that maybe become a very important model of sort of virtual multidisciplinary consults. And curious, has any in the group mastered this or doing this now, or what are the thoughts?
I mean, I can just say that we haven't started doing multidisciplinary patient evaluations through like a Zoom type of thing, but we have multiple sites across New York City where we're practicing oncology. And one of the things that we've been trying to do prior to the COVID situation was having video conferencing for our tumor boards and our all of our multidisciplinary tumor boards. So, and those were well attended, but we couldn't see people as well. And they were sitting at a table and it was difficult to hear. And I think we completely moved over to a Zoom model for all of our multidisciplinary tumor boards. And we have more participation. You know, people are calling in, you know, we have, you know, 40 or 50 people on a call for some of these tumor boards. And I think it's been incredibly useful to really develop the conversations across the system. And because there were so many issues, as Dr. Wei was mentioning about sequencing patients with, you know, making decisions about tiding somebody over for a period of time until they could go for surgery, that we really needed that multidisciplinary input. And actually the collegiality that came out of it, and the actually the ability to socialize in some ways during this time when everybody was sort of isolated was very positive. So I think that this will help us to continue working in a more multidisciplinary fashion, because that is a major part of being in GI oncology, is having the input of all of the different groups. And I'll just echo Dan's point about the use of the telemedicine for and the ability to enhance enrollment on clinical trials. I think one of the things I encountered when I was in Colorado, where we had, patients who were able to come for an initial consult to Denver, but for being enrolled on clinical trials, it was not feasible. And I think we can be much more pragmatic now about thinking about putting patients on trials, even if they are, living several hundred miles away from the main center. If we can really collaborate more with our local partners and not have the restrictions that have been, historically laid upon us to only have patients treated at a central site. So I think there's potential for a lot more flexibility and enhancement of our clinical trials program.
I think this is a really, really important point, and I think it is going to be absolutely practice changing, and especially for some of the sort of biomarker strategies for rare subtypes of patients that don't have access because of geographical constraints. I'm thinking more about oral agents, perhaps more so than IV, but that this will impact how we do clinical trials. There's no question about it in some very positive aspects.
Maybe before Dr. O'Reilly, before you take us in our first case discussion, I want to make sure we get there, but I'm very interested in knowing, and this is in part because we're trying to formalize a policy at our cancer center, is who are you all testing in terms of doing COVID-19 testing, both staff and patients? Maybe Stephen, if you can start with answering that for your patient. Let's start with your patient population. Again, this is something that I don't know if we have great data to drive us, or maybe some of your institutions already do, but I'd be very curious in terms of both now and sort of your plan going. There's some questions that have come up in terms of, well, what does the future hold? And I think testing is a big part of that.
Yeah, thanks, Andrew. You have touched on a very controversial part. We actually, even in Hong Kong, we, in the community, in the medical setting, government, people, there's a lot of debate. Whether, of course, there's a group of infectious disease experts or some doctors who advocate massive testing for all the people in Hong Kong. Of course, there's a lot of limitation, especially on the number of the case, and this will cause some implications on the social distancing. And at this moment, we are still only testing for every patient. First of all, in the hospital, we only test when they have symptoms, fever, or any positive history of contact history. So we don't test those patients who are asymptomatic, who have no fever, or just request to be tested. This is our routine in Hong Kong yet. Of course, sometimes I do receive some strange requests from our community. Say, I remember a few weeks ago, I sent a patient to a radiology center for PET CT scan. And because they are worried this patient come from a hospital, so they rejected the patient and sent us some requests that they want to test the COVID-19 for this patient. But of course, at this moment, this patient have no symptom, no contact travel history. We don't routinely test for the patient. So this is the moment now, but it may be changed later when maybe the government changed the decision, but we don't test generally for all the patients without symptoms or suspicious history. Yeah.
Thanks.
How about the States? How about the testing in the States? In the United States, what's the criteria of testing COVID-19?
Yeah, Dan, what's going on in Chicago?
Yeah, so this has been a work in progress. I'm sure we were talking about, like, it's changing on a daily basis in many cases. And up to yesterday, we weren't routinely testing our patients, say, getting chemotherapy. But just as of yesterday, we had a direction that all patients that are starting new chemotherapy will be getting tested for COVID. Before that, weeks ago, all patients, of course, coming into getting treated were getting at the door before getting put back into the IV therapy suite, check for vitals and temperature, etc. And so, again, this is all changing in real time. So as of today, from yesterday, we will be checking all of our patients that are new starts for chemotherapy within 2 to 3 days of starting the treatment. And as another example for endoscopies, and I think we'll be getting into that in some of the cases, but at one point all of these types of procedures were shut down during the height of all this, and then eventually there was a requirement that all patients would get tested for COVID and required to be negative before proceeding on to getting these types of evaluations like endoscopic ultrasound or upper EGDs and things like that. So that's what we're doing as of today. Now, I can speak from my own portfolio of patients. I've actually only know of one patient that's actually tested positive of my own patient portfolio, and I've only actually tested up until today 2 or 3 total patients because that, as we mentioned, we were only testing patients who were either symptomatic or had a reason to do so. So it'll be interesting to see what this sort of pan screening will look like, and what the incidence rates will be, and we have to take into account the false positive rates of all of these tests, and what are we going to do with that now? Are we not going to treat them? Otherwise, we were ready to start treatment, and these are going to raise new questions, I think, that we're going to be faced with.
Yeah, I think this is a very important practical point that we're beginning to see patients now who've gotten through the acute phase of the illness and are, their disease is progressing. A patient that will need to address this at the beginning of the week is how are we going to bring that person back to the clinic, and what extra support do we need, and what's the right timing for starting treatment, and a sort of the tension between wanting to wait but at the same time knowing that the disease is evolving and not having black and white answers in terms of how to approach it. I think there's going to be a big learning curve on this over the coming months as we all embrace the fact that COVID-19 is the new normal, and a lot of or portion of our medical care is going to be devoted to looking after and supporting these patients.
So in New York, where the prevalence is considerably higher, are you say before a patient gets started on outpatient chemotherapy? So at UCSF, we also decided on, all right, inpatients, yes. Before aerosolized procedures, yes. Before surgeries, yes. But I think we're grappling with the, should we be testing them before starting radiation or chemotherapy? And if so, it's obviously just at one point in time isn't going to be sufficient. Do we need to test them every cycle of treatment? Those kind of very practical questions, especially when our testing capacity is improving compared to where it once was.
At Mount Sinai, we are testing before beginning of each cycle of chemotherapy. We're not testing before radiation therapy. Part of the reason for that is because they're going to be coming in daily, and that status could change throughout. And there's also been some data from China showing that patients getting radiation didn't have a higher rate of mortality from COVID-19. Whereas there could be some association between being on chemotherapy and mortality from COVID-19. So we have not been doing it for radiation therapy. But the other question that has come up is, should we test patients before consenting them to go on a trial? Is that something that we should be evaluating, and timing of that when you consent versus when they actually start treatment? You're going to have to do another test before they start the chemo. So we're actually starting a working group amongst our oncology colleagues to look at some of the testing time points and when, and even if the type of chemotherapy is important, should we be looking at, more of the, only for patients getting bispecifics, not if they're just getting, weekly Taxol. So these are a lot of the questions that are coming up, and we don't really know the answer.
So maybe we'll go to a case just to focus back in on GI and to use that as the focal point for discussing management in the context of COVID. And Alice, I'm going to spotlight you here to get us going on this. So let's take a patient with newly diagnosed, untreated, resectable pancreas cancer. So a person that we could take to the OR tomorrow, but at the same time, we know neoadjuvant therapy is an emerging strategy. Kind of walk us through how you think about that. What are the key pointers, and from the surgery point of view, and then maybe I'll ask Michael just to comment on the neoadjuvant medical perspective.
Well, and thank you, Aline. So, as you everyone knows that for resectable pancreas cancer, the standard approach has been surgery first, followed by adjuvant chemotherapy. There has been a lot of interest in a neoadjuvant approach for all localized pancreas cancer, and I certainly think that for borderline resectable or patients with locally advanced disease, that all of us would recommend chemotherapy first as the new emerging standard. I would say for resectable, I'm still a little bit torn. I think there's really true equipoise about what the right treatment is. And, as you know, there are multiple trials that are either underway or have recently completed, which including the SWOG 1505, which show no clear demonstrable superiority for neoadjuvant chemotherapy first. That's not to say that we're not interested in that therapy, but I think there's still room for considering surgery up front in the resectable group. So, generally that we do, with the evidence in mind, we also look at the patient's symptom burden. So for example, if they are jaundiced, they have yet to undergo an ERCP and drainage. In that patient, we may lean to surgery first because that would treat both their symptoms and their cancer, utilizing the least resources actually and exposing the least to the opportunity of catching COVID. And we would balance that obviously with the other side of the equation, which is that if their symptoms are relatively well controlled, there are prognostic factors that are not favorable, then we would lean toward more of a neoadjuvant approach, understanding that is going to be an emerging standard, reasonable approach for even the resectable group. And maybe I'll open it to other of the panel members to get their input as well and on that.
Yeah, Mike, do you want to add here just on neoadjuvant, what you're thinking, what choice of regimen given the new data that we have?
Yeah, no, definitely. I think that this does definitely vary by institution. And at our institution, we do prefer a neoadjuvant approach even for resectable cases. My philosophy on the choice of neoadjuvant regimen has not necessarily been affected by the COVID-19 situation. Whether FOLFIRINOX or Gem/Nab-Paclitaxel, certainly Gem/Nab-Paclitaxel allows the patients to have potentially fewer medical visits, but many of the disconnects for FOLFIRINOX we have been handling for a long time with nurses going to the patients' homes. So it's a little bit less of a concern for patients having to come back to the hospital for the disconnect. I'm impressed to hear Andrew and Dan talk about testing before every chemotherapy. I hope that we get there. We're not quite there yet, because certainly when I'm starting a patient on neoadjuvant FOLFIRINOX or Gem/Nab-Paclitaxel, it does get me a little bit wary. But we also know that we need to get these patients started on treatment as soon as possible. These are pancreatic cancer patients after all, and many of them are very symptomatic. But I think overall, these are patients that need to get started on treatment. So if you're an institution that wants to do surgery first, I think doing that right away is still a necessity. I think if you're an institution that has been favoring a neoadjuvant chemotherapy approach, which again, both right now are neither is wrong, neither is right, I think that also needs to get started right away. One question I have for whoever I hand this off to, I'm curious, our interventional radiologists have actually been very, very restrictive on the procedures that have been done, and even Metaports, which are being done, they're being done with a lot of need for approval, and are you sure you really need a Metaport for this patient? So obviously for FOLFIRINOX, all these patients need Metaports, but for Gem/Nab-Paclitaxel, for Gem/Cis, for other regimens, it's been, can you get away with just using a peripheral IV so that we can avoid the procedure? I'll leave it to the panel.
Yeah, that's an interesting one. I think perhaps less so for ourselves. We do routinely test anybody for COVID procedures and certainly pre-surgery and any interventional GI or IR procedure. We are not as yet doing it routinely pre-chemotherapy, because I think one aspect, I think it's very important to do it just from the learning and understanding what it means. but I'm just thinking about it. So we've an asymptomatic patient who's symptomatic from their cancer, but maybe asymptomatic positive from COVID. Does that mean we shouldn't consider treatment? I don't think we know, right? It's a lot of unknowns, but huge opportunity for learning. And I heard a nice point from Stephen, just how the medical community, I think how the community in general, even though we're physically distanced, is more connected in ways, and we're learning from others. I think even just hearing how on this forum people practice is educational to us all, I think. So we've a couple of questions. One of these I think is a good one, and just because we're an academic group on the forum. So how are we interacting with our fellows and residents, and what's been the impact in terms of education? Maybe Andrew, would you like to speak to this?
Yeah, this is very difficult because in terms of defining who was an essential worker at our institution, sort of where residents and fellows and students fit into that. We have worked out different systems in terms of active versus passive learning, even on Zoom calls, and developed a system whereby our fellows can actually play essentially the same role that they did with the in-person visits in terms of gathering all the data, even doing the initial intake and visit with the patients before the attending comes in. I think we have to be committed to the greater amount of time that kind of setup entails. But for example, for seeing inpatients and things, frankly, a lot of our fellows have been pulled from their services and or are doing, say, consults remotely or just through Zoom or telephone visit for the time being. Thankfully, we're now in a recovery phase where they're being worked back into practice, including seeing patients in person more. But I think there was a very, I'll say, protective element in terms of wanting to make sure our trainees were kept from excess risk from exposure.
Yeah. Karyn, what's happening in the radiation world in terms of teaching, and how are you doing this?
I think our situation was actually more impacted by the fact that our entire institution became a COVID-19 hospital. We had, in our 7 Mount Sinai hospitals across the city, at some points we had, 2,500 COVID-19 positive patients. So we actually redeployed almost all of our residents from radiation oncology, dermatology. All of the hem-onc fellows were on the floors or in the ED taking care of COVID-19 patients. So for about 6 weeks, we lost all of our residents. Prior to that, the redeployment, they were working from home, and we were trying to work out a way to do, so for the video visits, they would oftentimes review the patient's information, present the patient to me, and then I would call the patient for the video visit. But one of the most important things for radiation oncology is really some of the contouring work. And so we continued to do that through Zoom. So they would contour, we would do the simulation. If the resident was in the hospital, they would come to the simulation with me. If not, we would just go over the case later, and then they would do the contouring, and then I would review it with them with Zoom. It hasn't been ideal, and I think the fact that we didn't have residents for 6 weeks and they were completely focused on the COVID-19 patients was difficult. But I think they all have come back this last week, and they really had to commit themselves to that, because it was incredibly, I think, to some extent, life-altering to be part of this. But we're really excited to have our trainees back, and I've been working with them through either Zoom or some in-person meetings when they're in the hospital. But we are trying to minimize their time in the hospital, because they also work in a small resident room where we don't want them. It's very difficult to socially distance. So it'll be, we'll see how things work going forward. I don't know when we'll be able to minimize those those issues in terms of social distancing.
Yeah, I think when we're all in crisis mode, it sort of teaching and education took a little back focus, understandably. Not that there isn't huge learning opportunities from COVID, there is, and we're all involved in all of that. But I think now that things are starting to settle, it's something we have to think about, just how we're going to keep up optimal educational opportunities for all our trainees. And Alice, I'm sure this is very key also in surgery, where exposure and training and doing procedures, and how are you addressing this?
Well, certainly at the beginning, we did everything we could to reduce the risk to the trainees. So the medical students, any resident who wasn't required, or any resident or fellow who was not required to be in the OR, we asked them not to scrub, because initially it was not clear what the risks to them would be, even from a laparotomy. So that was not considered initially a high-risk procedure. I think it's still a little bit unknown, but certainly at the beginning we tried to be as safe as possible. As we have learned more about COVID and risks in the OR, we are obviously trying to reintroduce them slowly, and it's been a challenge for them as well, because for surgeons and surgical trainees, they learn by operating, and when the case volume goes to 75%, 50%, 25%, or zero in many cases, that really diminishes their opportunity to learn. We have been trying to substitute with things that we usually want them to do but don't have time for, watching videos, particularly minimally invasive surgery, and trying to re-engage them now in Zoom conferences, and rounds are getting started again. But I do think that particularly for the people almost done their training, they do feel that they have missed an opportunity that they otherwise would have had.
So should we go to another case?
Yeah, Dr. O'Reilly, before you do, I just, to close out the whole neoadjuvant pancreas discussion, it's probably worth a shout out to the Alliance trial that is about to activate this summer. So as we know, adjuvant FOLFIRINOX is the current standard of care for fit patients after they've undergone an upfront surgery. So a big national trial that Dr. Christina Ferroni is leading will actually look at this question of preoperative versus post-operative FOLFIRINOX for patients with clearly resectable disease. And that duration of preoperative FOLFIRINOX is going to be 8 cycles before surgery, and then finishing up with 4 cycles afterwards, versus upfront surgery followed by the standard 6 months of FOLFIRINOX. So I think that should get us closer to that clear answer. I think surgeons and med-oncs really want to know, in terms of, if you've got a patient with a newly diagnosed clearly resectable disease, how should our paradigm perhaps be changing? I think that study will be very informative.
Absolutely.
Yeah, completely agree. I think it's, as Alice mentioned, it's the sort of equipoise in this area in some, not everybody's minds. And at ASCO, we heard a preview, we've mentioned a little bit on this call about the SWOG study, looking at gem-nab-paclitaxel and modified FOLFIRINOX in a perioperative setting. And I think perhaps a little surprising that we didn't see a bigger signal there. We also some nice data from Europe that I think leaves this very much an open question of patient selection, and which ultimately is going to be the right strategy. So kind of a hot topic in the pancreas cancer world, and I think sort of stay tuned for more details soon. So maybe we'll switch it over to HCC for a few minutes, and a lot happening. In fact, almost every day, right? There's a new announcement or a new immunotherapy in HCC. Stephen, do you want to give us a quick synopsis, and maybe we'll just position it around a patient who has localized disease within the liver, who's a candidate for regional therapy, and also candidate for TKI, also candidate for immunotherapy. What's your thinking in the COVID-19 world of how we approach this patient?
Thank you, Eileen. Maybe I try to set the stage by, say, early stage, intermediate stage, and the advanced stage. I think for the early stage is quite straightforward. Surgery is still the standard. Of course, if those tumor which is in the right locations and the size is within the ablation limit, ablation like radiofrequency ablation is another standard treatment for these early stage XCC. If you in the context of COVID-19, if you try to look at the Italian experience, because they are seriously affected by the pandemic, and they tend to move some cases from surgery to more ablation if it's within the criteria. And of course, if in Hong Kong we are not that affected, but if really you expect the surgery to be really take a long waiting time, maybe alternative upfront treatment like even immunotherapy, TACE may be an alternative. Going back to your the intermediate stage, which should be usually the standard is a regional treatment like TACE, while we only treat multiple cycles TACE till the patient become refractory, then we switch to the systemic therapy. And for the upfront systemic therapy, we reserve those metastatic disease. I think this concept is being now challenged, and the line between the intermediate stage XCC and the advanced XCC is quite a bit blurred nowadays. One of the reasons because we know the TACE can, when you give multiple cycles enough, especially for large XCC, can damage the liver function and somehow affect the prognosis. And also, we know that from systemic therapy, we have more effective agents apart from the TKI, sorafenib or nivolumab. In this week, in the New England Journal of Medicine, we know one of the combination, the bevacizumab plus the atezolizumab, has demonstrated improvement in the overall survival response and the progression-free survival than the sorafenib. So, and also they do have some quite reasonable response rate as seen, also sometimes even CR. So I think now the XCC was gradually or trying to see or we think about the role of systemic therapy. In some cases, for example, with big disease burden, even the disease is still within the liver. I think some people may think maybe the patient should be better treated with the systemic therapy like the atezo and the BAF. I can imagine, and actually I know that there will be some coming clinical trial comparing the TACE versus the systemic therapy in the future for those with more high burden in the immediate stage. So I do expect the XCC management will be dramatically changed in the next decade, especially about how to combine or how to position the TACE versus systemic therapy. This will be an important area. Talking about the COVID-19, I think if the places are really seriously affected by the COVID-19, maybe for the TKI, the patient may be followed at less frequent. Maybe we can monitor the toxicity by telemedicine. For the nivolumab, pembro, or other PD-1, some of our patients be treated with, instead of every 2 to 3 weeks, we may lengthen it to 4 to 6 weeks to minimize the nosocomial exposure to the COVID-19. But of course, this is a temporary measure. I think in the long run, we'll switch back to the ordinary way of infusion. Yeah, that's my thought about the XCC management. Thank you.
Great, thanks so much. That's very helpful to hear your perspective. So we thought maybe for the last kind of 10 to 15 minutes, we would tackle the topic of biomarkers, because there's a lot happening across the whole GI field, and not to mind every malignancy. But Mike, this is your area of expertise. Can you kind of walk us through some of the key new data that we have in pancreas and hepatobiliary malignancies, and how you're using that in terms of practice integration?
Yeah, I'd be happy to. You know, we've been definitely in an area that's been very exciting for GI cancers and biomarker testing, because we're finding that patients with GI cancers definitely do have different biomarker subgroups that they fall into. And when patients are tested, specific biomarkers identified, and the patients get the appropriate treatment, they actually do tend to do better we were fortunate to be able to look at a retrospective registry. So unfortunately, not a prospective study. It's going to be very hard to ever do a prospective study to ask and answer this question. But in a large retrospective study through the Know Your Tumor database, we looked at about 1,000 pancreas cancer patients and subdivided it into those patients who had an actionable biomarker, those who had an actionable biomarker and got the right treatment, and then finally the larger group of patients, the 75% who did not have any actionable biomarker in their tumor. And what we found was that when patients actually are able to get, either through off-label use or through clinical trial enrollment, if they're able to get what we called matched therapy, matched to their actionable biomarker, that they actually had a survival for advanced metastatic patients that was 1 year longer when compared to patients who did not get the appropriately matched therapy or patients who didn't have any actionable biomarker at all. So it really was a shot in the arm for the idea of doing biomarker testing. And I think generally speaking, to make a bit of a blanket statement, I think we're seeing similar findings in upper GI cancer and biliary cancer and others. I think it really just emphasizes strongly the need to be testing these patient tumors to look to see if there is a mutation or other biomarker that can be acted upon. We have taken to doing routine germline testing for all of our pancreas cancer patients as per the NCCN and ASCO guidelines. But we also almost always will do somatic tumor testing, again, per the NCCN guidelines, to see if there's beyond just the potential for a germline mutation, if there's something that we can actually potentially act upon. One quick comment about the biomarker testing in the COVID era. I've actually, in some ways, stepped up my biomarker testing. The triggers to remember to go ahead and send that patient's tumor for biomarker testing has definitely been influenced by COVID, because as Dr. O'Reilly alluded to earlier, a lot of the biomarker-directed therapies are often oral therapies. They're often targeted therapies that have a lot less of the myelosuppressive effects that standard traditional IV chemotherapy does. And if by some just chance, dumb luck, that patient's tumor does actually harbor an actual biomarker that could be treated with an appropriate oral therapy, again, either on-label, off-label, or in the context of a clinical trial, then it might be a real blessing to be able to get that patient on that treatment, keep them away from the clinic, keep them away from the infusion center, put them on their oral therapy, do telemedicine check-ins to see how they're tolerating that oral therapy, and yet still have the potential for potentially better outcome than with the IV chemotherapy itself.
Yeah. Michael, just I know you and Eileen have led a number of important studies in the whole DDR, BRCA realm. Polo obviously made a big splash. Can you just maybe share a little bit about where we're going with that subset of patients in terms of current practice and upcoming studies?
Sure, yeah, I'd be happy to, and then I'd love to hear Eileen's thoughts as well. This is definitely the largest biomarker subgroup of patients for pancreatic cancers. About 17 to 25% of pancreatic cancer tumors harbor an underlying mutation in one of the DNA damage response repair mutations. We traditionally think of BRCA1 and BRCA2 and PALB2, but there's actually a whole list of other mutations that could have some potential impact on the ability of these tumors to be responsive to platinum-based therapies and to PARP inhibitors. The POLO trial established a progression-free survival benefit for using olaparib, maintenance olaparib, in the patients who have an underlying germline BRCA1 or BRCA2 mutation. We've seen similar data come out of UPenn with Kim Rice-Binder for rucaparib in a very similar maintenance setting. And in her case, actually, she did include patients who also had somatic, not just germline, but somatic mutations in BRCA1 and BRCA2. So I think that targeting the DNA damage response and repair pathway is going to be a very, very big part of treating these cancers. But the reality is, and there's some amazing data from Memorial Sloan Kettering, that we can't use any real filter for trying to identify who these patients are. We can't just use, for example, family history as a filter to decide who to test, because we may miss as much as 50% of these patients who actually do have an underlying DNA DDR mutation and who could benefit from these different therapies. So I think it just really reemphasizes the need to test and to have a strategy and test relatively early. It's hard to get testing done right away, but certainly within the first month as they start other therapies, so that you can have actually a strategy in place as to whether that's maintenance PARP inhibitor or a second-line clinical trial or other therapy that may be, again, geared towards that DDR mutation.
Yeah, thanks, Michael. I think these are all really good points. So we want to build on the signal that's been identified in terms of combinations, and there's a lot sort of happening in that space, and potentially integrating immune and PARP inhibitor combinations, and also seeing if we can induce a BRCA or a HRD signature to a wider group of people. That's a hot area too. I think some parallels have been shown in ovary and maybe to a lesser extent in breast cancer. We're sort of learning whether we can apply some of those strategies in pancreas cancer. But I think this whole topic brings up an important one of, specimen acquisition and how we're doing this in the current climate, and can we do this? Blood, I think, obviously is pretty doable, but just recognizing the constraints of research labs being on hold and all of the, the fancy things that we like to do. What are the core clinical things that we need to make decisions? And I think to your point, that just emphasizing the importance of trying to find these patients by doing universal germline testing. And I would argue, but interested in the group's approach too, we should be trying to get tissue on everybody and trying to sequence as well, even in the current climate, because of those rare but important actionable findings that can impact. And I think the data that you showed in that paper, acknowledging some of the selection criteria, are profound. I mean, a year difference in metastatic disease is, whatever way we cut it, that's striking. We want to do better, but it's a real signal. So we need to find these patients and to treat those patients accordingly. And Michael, thank you. You've added, but I was going to ask Dan here, just in a slightly different area, on the story in esophageal cancer, some of the work you've done with UGT101 DPD testing and just trying to strike that balance, toxicity, efficacy, and where you see that going in terms of the biomarker era.
Sure. So the UGT1A1 story, in terms of the enzyme that metabolizes irinotecan, which is not a new story, but it's something that sort of is re-emerging, I would say, and especially now where we're always trying to sort of optimize efficacy and limit toxicity of anything we do, that's what we do in terms of weighing the risks and benefits and making decisions. Now we have to sort of factor in the added risk of COVID-19. And part of the issue there has been we weren't sure what that risk really was or is, and even today, not really a great handle on that. But if there is a way to administer the same regimen with the same efficacy but with lower toxicity, that would be a value added. And so we had embarked on a study in the perioperative setting for gastroesophageal cancer with perioperative FOLFIRINOX, but with the irinotecan dosing preemptively dosed and modified in those individuals with high-risk alleles, which is about 10% of society, and those with intermediate risk alleles, meaning heterozygous for the high-risk allele, at a lower dose that's intermediate dose. And so it was a single-arm study and as a pilot study, but just to show a proof of principle that with the primary endpoints of efficacy, these were quite similar to what we would expect, say, with FLOT. Yet the toxicity profile was quite better. And so that warrants sort of future investigation and sort of opens the door as a beachhead for other tumor types that may use FOLFIRINOX, for example, or irinotecan-based dosing like pancreas and colon and whatever, that could potentially administer the same therapy, but maybe at a lower toxicity rate in an era where optimizing toxicity is even more paramount, I would say, with COVID-19 prevalent. And so just as a reminder, the high-risk individuals, what that means is they're homozygous for a poor metabolizing enzyme. And when we think we're giving 180 milligrams per meter squared, they're getting twice the dose. They're essentially getting twice the dose. And patients who are heterozygous, who are giving 180 milligrams per meter squared, are getting 1.5 times the dose. So all we're doing with this preemptive dose modification is getting their dose to be effectively the same as a wild type low risk individual at 180 effectively. That's what it's doing through a simple blood test that's a 3-day turnaround. So if we could do that, it really isn't that much more effort. And so there are some designs being planned in the cooperative group to address this, say, in the first line setting, and FOLFIRINOX versus FOLFOX, for example, to see if we can improve efficacy but limit toxicity compared to, say, the parent FOLFIRINOX regimen. So that's that. And I'll just add a few comments about genetic sequencing and profiling in the gastroesophageal space, quite similar to what's been discussed in the other upper GI cancers. And of course, we have to check for HER2, and some of that's reflex through tissue, but there's a whole host of other genomic targets that are difficult to prove, similar as Michael was mentioning, and having to sort of go back retrospectively. And we've been sort of trying to find new ways of studying that with novel clinical trial designs, which is our Pangea study. But in real life, in our patients, especially at the height of this COVID, where a lot of the staff that was involved in sort of triaging the samples and getting them sent for the various molecular testing, that was all shut down. And so we were wanting to get the NGS testing, but it was not really feasible for a period of time. And so that really speaks to the advantages of blood-based testing again, where that could be, done through mobile phlebotomy. And, I was meeting new patients on Zoom and getting mobile phlebotomy out to them. And within a week, I know their genomic profile, and I could order an oral targeted therapy, and they've never stepped their foot in our system, but we've been able to treat them appropriately. So I think that's another one of the things that already, that's one of the selling points, say, for ctDNA, the convenience, and you don't have to get biopsies, it's less invasive, etc. But in this era, it's even more highlighted in a way, and so that may come to become more routinely used, I would say.
And while you still have the floor, I'm guessing this audience would be interested in how your approach to IO therapy for advanced gastric and esophageal patients. Obviously, we have different, say, keynote studies that have looked at this in the first and second and third line settings. So let's say you have a patient with a high CPS score. Or in what context might you even think of using an immune checkpoint inhibitor in the first line setting versus waiting until someone has progressed on chemo?
Great question. So in the pre-COVID era, we had, just to lay out the current standard of care, and FDA approvals, of course, are in the third line setting for PD-L1 expressing tumors of a CPS 1 or higher score. And like any solid tumor, that's MSI high in the second line setting. And so that's sort of the standard to date in terms of approval for adenocarcinoma. And then esophageal squamous cells are CPS score of 10 or higher in the second line setting, both for pembrolizumab, Keytruda. And so, before COVID came around, there were some signals in the second line study, which is Keynote 61, and in the first line study, which is Keynote 62, of patients that could look like they were doing better in head-to-head randomized study of monotherapy pembrolizumab versus the chemotherapy arm, but just in a subset of patients. And, in retrospective unplanned analyses, we are seeing that tends to, certainly is MSI high tumors. So even before COVID, I think there was consensus that although the approvals in second line, that we should strongly consider, as I do, using immunotherapy for an MSI high tumor at newly diagnosed disease in the first line setting. There was evidence to support that. And so in terms of other biomarkers, maybe CPS higher levels, whether 10 is the number or something higher than that, to enrich for a likely responder. And the reason for that is because although there was a signal of benefit in a subgroup, there was also a signal of detriment in another large subgroup of the same patients that, in the Keynote 62 study, who were already selected to be CPS 1 or higher, and they were still having worse outcomes in terms of survival compared to control. So we first want to do no harm, and so we really want to know that we're giving it to the right people and sparing it from the wrong people, right? So that's pre-COVID. And so now we have, in the interim here, we've had an approval of pembrolizumab dosing to every 6 weeks. And we're trying to limit people from coming to our center. And so, you know, that makes me think a little bit and say, maybe that patient in second line that has a CPS score of 20, you know, and normally I would be more adamant that we need to be really more judicious and get more data before we start doing this. It's certainly not approved, but now I might give them that dose of pembrolizumab, and, you know, they don't have to come to the center for 6 weeks, and they're getting at least an enriched approach to their treatment, and they have certain biomarkers that would suggest that they at least have a better chance of deriving benefit. So it's a moving target, but COVID has sort of altered my way of thinking and the risk of treating these patients.
Absolutely. You know, Dr. Oral, I think I'm paying attention to the clock. I know we're approaching the 90-minute time that we were allotted, and I wanted to maybe close out this session by, and there are a lot of questions that have come, and I apologize for everyone who's asked a lot of questions on the Q&A that we can't answer all of them. Otherwise, this could be easily a 3 or 4 hour discussion, which would be fun, but I think I want to be sensitive to people's time. But maybe just as a broad closing, there are questions in terms of what the future holds, and maybe to end on hopefully an optimistic note in terms of what panelists sort of see in terms of what the future holds in terms of what will be permanent changes or just long-term changes, even as we perhaps get to the flattening of the curve or the recovery period, or, you know, up until a vaccine becomes available. Just your perspectives on the sort of the next 6, 12, 18 months, and just sort of the future. Does anyone want to weigh in?
Can start. I think it's, you know, it's been obviously a hugely unexpected, although somewhat anticipated, set of considerations that emerged with the whole pandemic from earlier this year. I think we wouldn't have wished it for anybody, but I think there will be a lot of very positive changes in terms of how we practice medicine, how we interface with patients, how we collaborate with our colleagues, how we conduct clinical trials. I think there'll be some elimination of redundancies and perhaps less value-added medical care, and really kind of striving to get to the core of what we need to do. And I expect it's going to be a continued period of change for the next 6, 12, 18 months till we're, you know, have hopefully a good handle on the pandemic. But I think COVID is probably here to stay, and that we're going to be, you know, needing to address this. I think a vaccine will in part, I think herd immunity in part, I think testing and tracing contacts will all in part be how we go. But we know from other viruses, right, from influenza, from other coronaviruses, that they're out there, but hopefully at a much lesser impact than we've all witnessed in these last several months.
Yeah. Stephen, since you're representing all of Asia, do you want to share with us sort of your perspective on how things are going to look in the next year or two in Hong Kong or just in your part of the world?
Yeah, Andrew. A few things. I think I'm a bit more pessimistic in the sense that probably this time the COVID-19 is a bit different from the SARS and the MERS, which basically they disappeared. given the size and also is high penetrance, a lot of people will be affected. I think it will subside one day for the pandemic, but it can easily come back. And also we are bound to see some, like influenza, some of the seasonal variation. This is my worry. So I think for the medical services or research, we need to have some plan, in the sense that maybe we should have some contingency plan in case it come back again. What will be the role of each staff? For example, if really some of the non-essential staff which are in the home office, what will be their role in terms of the maintaining services? For those more frontline staff, are there any SOP which are the medical world can decide? Of course, it's based on the regional and institution. But I think we need some sort of these contingency plan in the future. I don't know. I don't know whether vaccine, herd immunity. In Hong Kong, there's a lot of debate whether really general whole world people vaccination really can eradicate the virus. We don't know yet. But I think we need to get prepared. And I agree with all of you that telemedicine, and we need some new standard in the future in terms of research, clinical trials, and also approaching our patients. In Hong Kong, at this moment, we are thinking about how to minimize the number of people waiting and the waiting hall. In the past, we are basically too crowded. We get 50, 60 patients waiting in the waiting hall for chemotherapy. I think now it comes to the hospital decision that we need to space them out. We need to maintain some sort of social distancing if whenever possible. So I think this is something that we need to pay attention to in the future. But in summary, we need to get prepared for this time. Yeah.
Yeah. Dr. Wei, do you see a floodgates of surgeries now as we sort of emerge from this? Or is there going to be a huge backlog of cancer operations that have been postponed for these past several months, and you and your colleagues are just going to be inundated? What do you foresee?
The answer is we hope so, because we hope that patients were merely delayed, and that as we come to thinking about recovery, we want to look at outpatient surgery first and get those moving. And certainly, I think we will see a flood. I do think we're concerned that there were patients who missed an opportunity for care because they either presented later or haven't yet presented, and when they do present, they're not going to be eligible for curative surgery. I think time will tell. I certainly know for elective surgeries as a whole, so including orthopedic or all sorts of elective surgery, there are huge backlogs. As I previously mentioned, I was in Canada, and there's over 100,000 backlog in one province that will take over 2 years to resolve, and that is only with a couple months break. So it's going to be an ongoing challenge. I think we are understanding that we can do surgery safely. This is a condition that we'll have to learn to live with. I don't think we're going to beat it immediately, if ever. I think this pandemic has helped us focus a little bit on the other side of the equation, about toxicity, about benefit, and made really explicit the need to discuss with patients, with our colleagues, and balance it for each patient. So I see that as an opportunity, and I think that some of this research things we do in the area in the future will also focus on that. Toxicity, balancing toxicity, whether or not whether or not plan drug holidays, whether or not some people can avoid surgery in certain situations. So maybe there's a good side to this as well. It gives us new directions as well.
Yeah, and then maybe I'll just ask one last question to Dr. Goodman. It sounds like you're sort of leading the way in terms of your clinical research efforts at your institution. What do you see as the future for cancer clinical research in the near and long term? I think we're all kind of maybe concerned or just uncertain about what the future holds there.
I think that's a great way to end. I think we're looking forward now to really re-engaging patients in clinical trials. Actually, as of Monday, we'll have our first phase of reopening trials And we went through a whole process of really looking at what were the studies that were the highest priority to open, but also had the least amount of resource allocation for our infusion staff. I think as Dr. Chan mentioned, that we can't have 30, 40 patients waiting in the waiting room. We have to do things in a way that's safe for our patients to come back in. We have to find a more efficient system. We're looking at using texting to let patients know when they're ready to come in. We're trying to communicate more between our research staff and the infusion staff, so that weekly we'll be sending the list of patients to come in, so that they know whether patients have had all of their testing done beforehand, whether it's COVID testing or just labs. So we're really trying to improve efficiency, make it safe for our patients and for our staff to be in the clinic. But I think what we learned, as a result of the COVID situation and the number of trials that we actually had to open to address the COVID patients in the hospital, we had an onslaught of all kinds of studies. And in fact, a lot of them were led by our medical oncologists, because they were studies using immune modulatory agents that were actually very commonly used in oncology, and that people had experience with those drugs. So we had a lot of interaction between our hem-onc group and our infectious disease groups. And we really developed a much more streamlined process of opening clinical trials. And I think, as everybody knows from the NCI designated cancer centers, the typical turnaround for opening a trial can be over 3 months. And we were opening trials in weeks. And so seeing that was very heartening, that we can actually do this and learn how to streamline our processes a little bit more. So I think there is potential to really, number one, improve our internal processes for opening trials. And I think using all of these new techniques, such as the telehealth options, will help us be much more nimble with enrolling patients on clinical trials, and hopefully have more pragmatic approaches to doing them.
Thank you. Well, I just want to thank all the panelists. It's been really enjoyable discussing with you these hugely important topics. I enjoyed doing this without having PowerPoint slides. Also, I think that was just sort of a fun and different from what we usually do. I want to thank the audience who tuned in and for all the questions, which again, I apologize that we couldn't get through all of those. Dr. O'Reilly, do you want to give any closing comments yourself?
Absolutely, completely echo those thoughts. Thank you to everybody. It's a beautiful day here on the East Coast, and to enjoy that, and hopefully for Dr. Lam to get some sleep, as he's kindly joined us 12 hours ahead. So thank you very much. Really appreciate everybody listening in today.